Okay, good evening. I'm Anna. I'm one of the cardiac surgeons at Baylor. Thanks to Dr. Parag and Jonah for inviting me for this talk with the fancy title. I'm really just going to review some alternative access sites for TAVR. I have no disclosures. So here's an overview of the most commonly TAVR access sites. So we're not going to talk about good old transfemoral access today, which remains the gold standard, but talk about these other sites when the femoral or iliac arteries are not suitable, like in this patient who had rocks for arteries. But non-femoral access is most commonly achieved with extrathoracic, transcarotid, transaxillary routes. Intrathoracic routes such as transapical are still used, but less frequently. So starting with the extrathoracic access site. So the axillary artery, it's an attractive route due to its extrathoracic location. It's easy for surgical or percutaneous access, and the size is often big enough for TAVR delivery system. And transaxillary TAVR, it's often described as more subclavian, but supraclavicular access via the true subclavian artery is pretty uncommon. A small incision is made at the deltoid pectoral groove to get down to the artery, and at times when the axillary artery is really deep, you can do an end-to-side graft that can be sewn onto the artery to make delivery of the sheath and valve a little bit easier. We usually use the left axillary artery just because the pathway is more direct and the optimal valve alignment with the aortic annulus. Complications are stroke and artery pseudoaneurysm, and the brachial plexus is really close by, often is draped right over the artery, so dissection can stretch or injure it. So outcomes with transaxillary TAVR is pretty good. There's a high procedural rate of 97%. And there's low major vascular complication rates shown here in this large observational series, but stroke rates are consistently pretty elevated, around 6 to 7% for both the balloon expandable and self-expandable TAVR systems. So another extrathoracic is the carotid artery. It's also pretty convenient because it's a large size, it's easy for surgical exposure, and has a good favorable angle to the ascending aorta. So a TAVR CT is usually enough to determine whether a transcarotid or access and is usable, and additional cerebral imaging is usually not necessary. So the carotid artery with the worst ICA stenosis on imaging should be used because it's going to be occluded during the procedure anyways. Most cases are performed through a surgical cut down, and once exposed, the carotid artery is encircled with some vessel loops, and then you access it with a needle, exchange for a small sheath over a wire, and then you do a transverse arteriotomy to introduce the valve delivery sheath. The similar large observational studies here show that transcarotid access, the mean stroke TIA rates at 30 days, major bleeding, major vascular complication rates are pretty low, and stroke rate is also it's lower than for transaxillary access. And I think the lower stroke rate with the transcarotid access compared with other non-femoral access sites is because the carotid artery that's distal to the access site, we clamp it and we flush it prior to unclamping, and it really protects the brain from emboli. And then transcarotid access, we also avoid transversing the origin of vertebral arteries. So another extrathoracic approach, the transcaval approach, where you essentially make an aortocaval fistula for delivery of the valve. So briefly, you have this electrified, this wire that's advanced through the walls of IVC into the abdominal aorta, and then it's ensnared in the artery in an area that avoids branches or bowel, and it's in exchange for a stiff wire that permits access to the aorta. And from there, valve deployment is pretty similar to transfemoral. And then the transcaval tract is closed with a vascular occlude device. This technology utilizes permissive transcaval physiology, where the aortic bleeding decompresses into the IVC. The IVC puncture site, as both an intact retroperitoneum and aortic pressures are higher than venous pressure, and this avoids retroperitoneal bleeding. There's some early studies that show that transcaval TAVR had a good outcome, but also there were significantly higher major vascular complications, including needing a covered stent, and up to a third of patients require some transfusions. And stroke rate was higher than for transfemoral, but lower than for transaxillary. So moving on to intrathoracic access, so that's transapical TAVR. It was the primary alternative access for the PARTNER 1 trial, and it's approached via a left anterior thoracotomy. And then transaortic, you can do it through anterior right thoracotomy or upper sternotomy. So transaortic is generally preferred over transapical, especially for patients with severe pulmonary complications, patients with hypertrophic myocardium. And contraindications for transaortic include if your ascending aorta is really calcified, if you had a prior CABG with vein grafts coming off high on the aorta. A CTA is used for preoperative for planning to determine the most optimal location on the ascending aorta, like what is shown here. And then transapical access is not used very commonly, but could be very helpful in a case such as this. It's a case that we did a while ago where the patient had a prior freestyle root and a valve that was calcified, and then a prior ascending graft that had a really sharp bend here that made all the other access routes challenging. So the transapical was allowed us to get deliver the TAVR valve. So looking at all the alternative access sites since 2015, I think transcarotid has rapidly become the most utilized non-femoral technique for both balloon and self-expanding TAVR valves in North America, while intra-access has declined, I think partially due to these studies. Like this is a recent meta-analysis that compared extrathoracic versus intrathoracic approaches, and it showed that intrathoracic access was associated with an increased risk of all-cause mortality at 30 days, longer hospital ICU stays, and then higher risk for major post-operative complications like AKI. I think there's a multitude of reasons for this, but I think not having a usable extrathoracic access site is an indicator of the comorbidities of the patient and kind of put them at higher risk for complications. So summary, there's really no standard way to choose the optimal alternative vascular access, but I think vascular access analysis, it should be reviewed in detail for any patient by a heart team, and then institutional operator experience should be considered. All three extrathoracic non-femoral access routes appear to have similar mortality, but the transcarotid approach appeared to have much lower risk of stroke across multiple published studies. And if all the extrathoracic access sites are not able to be utilized, you can still go intrathoracic. I think given the published data, observational experiences, in terms of non-femoral alternative access sites, I think transcarotid should be the preferred site if possible, and then transaxillary. And then transcaval, although even as an aortic surgeon, gives me a little bit of heartburn, but after that, followed by the transaortic and transapical approaches. Thank you.